Hi, everybody. I'm Mauricio Towen, and I have the honor of introducing today's speaker, a very valuable member of our department, Dr. Annette Chrysanthe. She is a tenured professor and our vice chair for research. She holds a Ph.D. in epidemiology, specializing in psychiatric epidemiology. She has conducted mental health services research and patient-centered outcomes research for the last 25 years. In fact, she was the first UNM School of Medicine faculty who received a PCORI grant. Her aims in terms of the research she conducts is to increase access to behavioral health services in rural and underserved communities and to vulnerable populations, including people experiencing homelessness and those involved in the criminal justice system, by developing, implementing, and evaluating innovative approaches to treatment. So, in other words, her research is very focused on her goals, which are obviously laudable. So it is an honor for me to introduce today Dr. Chrysanthe, and her presentation will be on the impact of permanent supportive housing in New Mexico, results from a 12-year-long community academic partnership. Dr. Chrysanthe.
Thank you, Dr. Towen. Let me get my slides up. Let me just see here. I'm going to go back to you, and I'm going to share screen. Okay, let's just hang on a minute. I'm going to try something different. Bear with me while I fumble through this. Okay, share screen. Okay. So can everybody see my?
Yes, we can.
PowerPoint. Okay. All right, and not the notes page, correct?
All good, Dr. Chrysanthe.
Awesome. Okay, great. Thank you so much, Dr. Towen, for the introduction. And thank you to all of those who joined Grand Rounds today. I know we have multiple demands on our time, and so really appreciate that you picked sort of spending the next hour with me today. Let's see, I'll just get that on there. Okay, so I have no conflicts of interest to disclose, and I'm going to be talking about three grants and a number of studies that resulted from three grants. And all of the grants that I'm going to be talking about today were funded by SAMHSA, and they were also, and the sort of the research resulting from those grants were all approved by our IRB. So I have three objectives for this talk, and the first objective is to describe the importance of a community academic partnership in conducting health services research. The second is to describe the impact of permanent supportive housing on individuals experiencing homelessness. And then the third is to describe the impact of COVID-19 on individuals experiencing homelessness. So a kind of a mixed bag of learning objectives. I want to take a minute before I kind of jump into the focus of this presentation, but I just want to take a minute to acknowledge several other faculty and staff in our department who have worked with me on these projects kind of along the way, and various agencies that have been involved in the research that I'm going to be talking about today. And last but certainly not least, all of the individuals who are homeless and who participated in the research that I'm going to talk about today. So for those of you who are not familiar with the agencies listed on this slide, they're all community-based agencies. The LifeLink is up in Santa Fe. HopeWorks, which was formerly called St. Martin's HopeWorks, is here in Albuquerque, just downtown. St. Luke's Healthcare Clinic is in Las Cruces, and then TOTA, Behavioral Health Authority, is up in Farmington. And so all of the data that I'm going to present today are really representative of New Mexicans across the state. Since I'm going to talk about 3 different studies that focused on homelessness, I thought it would be helpful to provide some data on the magnitude of the problem. So in 2020, there were about 500,000 people experiencing homelessness on any given night in the US. About 61% of those individuals were in sheltered locations and 39% were in unsheltered locations, living on the street or in abandoned buildings. In New Mexico, there are the most recent point in time counts estimated that there are approximately 3,333 people experiencing homelessness on any given day. What's really, really important to emphasize or recognize is that the point in time counts really underestimate the problem. Some research shows so much so by 50% sometimes in that these point in time counts are underestimating homelessness. So since joining, this my presentation today is kind of a journey down memory lane in a way. I joined UNM in 2010, and since that time, I've had the privilege of partnering with the Department of Health Behavioral Health Services Division, the acronym is BHSD, and various agencies in the community to address homelessness in New Mexico. And we've really done this through the framework of a community academic partnership. And so in a nutshell, community academic partnerships are characterized by involving community stakeholders as partners in research, right? They're not, we typically kind of go in and we kind of helicopter in and do research in communities, but within the framework of a community academic partnership, academic researchers and community members are really equal in that relationship. And there was a kind of a systematic review of all the literature conducted on community academic partnerships that was published in 2016. And through that review, they came up with a conceptual definition of a community academic partnership. And that definition is here for you on the slide. But the key kind of takeaway from this conceptual definition is that, again, equal control between academic researchers and community members. And so conducting community research within the framework of a community academic partnership is really different from the way community research has traditionally been conducted. So in the traditional way, academic researchers conceptualize research projects with minimal or perhaps any input from community stakeholders. The research focus has typically not aligned with community needs. It tends to align more with the academic researchers' sort of interest. And the interventions or programs have been or are implemented without a plan for sustainment in the communities. And newly gained knowledge and information is disseminated to peers and colleagues rather than to members of the community. And there's been a lot of research that has shown that this sort of traditional way of doing community research has not been very successful in translating research findings into practice. That there tends to be a real gap from kind of like collecting the data, generating the results, and then moving to real world implementation. And so when you conduct research within the framework of a community academic partnership, you really are able to create a system that enables the translation of research findings into action. And in these partnerships, community stakeholders can provide firsthand knowledge and insight on health problems, methodology, and appropriate evidence-based practices, which really increases sort of the research relevance and feasibility. And then community academic partnerships also create the ability to develop, merge, and really share knowledge and expertise among both academic institutions and community partners that promotes high quality research and capacity building. So, two most widely known sort of models of community academic partnerships include community-based participatory research, CBPR, or participatory action research. And as an epidemiologist, I'm certainly not by any means an expert in any of these methodologies, but we do have fantastic expertise within CBH and within HSC, within, with Nina Wallerstein developing sort of the CBPR approach. And so for any faculty who are interested in learning more about these models of community academic partnerships, please reach out to me and I can link you to the experts. All right. So before I move any sort of further in terms of talking about the studies that I want to get to, I thought it would just be helpful to take a minute to sort of describe the relationship that the Division of Community Behavioral Health has with the Human Services Department, Department of Health, kind of describe that relationship and how we've worked together for a very long time to identify clinical priorities in underserved communities, and then look for opportunities for funding to address those clinical priorities in underserved communities, to sort of expand services in those communities. And then we work together to, once we kind of find I noticed sort of a funding opportunity or request for proposals that aligns with sort of the clinical priorities that the Department of Health, particularly the Behavioral Services Division or CYFD, the Child and Youth Family Division, want to sort of address. Then we work together to identify agencies in the community who have the need, which is really important, and the capacity, probably more important than the need, to kind of partner with us to expand those services. Most of the grants that we have worked on with the Department of Health tend to be SAMHSA grants. But there have been some others, such as the Department of Justice, AHRQ, HRSA funding, for example. Okay, so in the studies that I'm going to talk about, the Division of Community Behavioral Health partnered specifically with the Behavioral Health Services Division to respond to SAMHSA sort of notification of funding opportunities. And they were at 3 different times. And I have a slide, I think it's the next slide, that will show you kind of the sequence of funding that we've received thus far. The grants that I'm going to talk about have all focused on the provision of evidence-based services to people who were homeless or at risk of homelessness. And so once the funding opportunity was identified, Dr. Eltschul and I took the lead on writing the grants. And in that process, we were constantly working with points of contact at the agencies that we identified to get information and sort of a plan for proposed services. And the agencies that are listed on this particular slide are also the ones that were on my second slide, I believe. So I won't go into detail in terms of where they're located, but these are the agencies that we've been working with now for 12 years in terms of addressing homelessness here in New Mexico. All right, so here's just an overview of the SAMHSA grants related to homelessness that CBH in partnership with the Behavioral Services Division have received, and I've been the PI on all of these grants. So the first grant was the Healthy Homes Grant, which was funded for 5 years between 2010 and 2015. Oh, I sorry, just saw a typo on that. It's not 2015. That'd be a very long period of funding. The second grant was the Housing Supports Health and Recovery for Homeless Individuals. The acronym for that is HHRHI, and that was a 3-year grant with the dates 2015 to 2018. And we now have a 5-year grant, also funded by SAMHSA, that's called Opening Doors. The funding for that project started in 2020, and it'll go through 2025. So this table provides an overview of the 3 different grants. And this table has a lot of information in it, so I'm just going to kind of take a couple of minutes and go through some of the details. In terms of the target population, all 3 grants targeted Santa Fe, and the HHRHI grant, as well as Opening Doors grant, also targeted Bernalillo, whereas the Healthy Homes grant targeted Tota, or in San Juan County, and the HHRHI grant targeted Las Cruces, and that's why we worked with St. Luke's. In terms of the target population, all 3 grants focused on adults who are homeless or at risk of homelessness with a serious mental illness or co-occurring serious mental illness and substance use disorder. With the Healthy Homes grant, there was a sub-focus on Native Americans, and so that's why we partnered with Tota up in San Juan. And in Opening Doors grant, the grant that I'm currently working on, we have a sub-focus on transition age youth. So the sample size for the Healthy Homes, we enrolled 237 individuals. In the HHRHI grant, we enrolled 403 individuals. And in Opening Doors, our target enrollment is 600. In terms of data collection, we Healthy Homes data collection protocol and Opening Doors in terms of the time point were identical. We collect data or collected data at baseline every 6 months while an individual was in services, and then again at discharge. And so sometimes the individuals, for example, in Healthy Homes, they were in services for close to 4 months, and so we had multiple up to as many, or sorry, 4 years. So we had multiple, up to maybe like 8 or 9 sort of reassessments on these individuals. So it presents a lot of opportunity to look at changes over time. The HHRHI protocol only required us to collect data at baseline, 6 months, and then 6 months post baseline, and then discharge. So that was a little bit different compared to the other protocols. And then in terms of what we use to collect data, all SAMHSA funded grantees are required to use the National Outcomes Measure. We use the acronym NOMS to collect data. And I'm going to show you what's included in the NOMS in a slide or two. But in addition to that, based on sort of the interest of the community stakeholders and what we kind of agree upon, we have added, or we add additional measures to track additional outcomes. And so, for example, we have consistently included the PCLC, which is the post-traumatic symptom checklist, civilian version to measure PTSD symptom severity. In the HHRHI project, we also included a measure of community integration, as the community integration scale. And in the current study or grant, which is Opening Doors, we have a measure of the perceptions of recovery. Another thing I want to point out is that with the Healthy Homes study, there was not a requirement. So housing was actually not a requirement for those enrolled in the project, which, as you'll see in the next slide, is contrary to sort of the model of permanent supportive housing. So in terms of the model of permanent supportive housing, which is the evidence-based practice that we used across all of these 3 grants, basically permanent supportive housing links subsidized housing with access to flexible voluntary supportive services to help people with disabilities. And in our area of study or focus, the disability is people with mental illness and or substance use disorders. And together, these 2 are to maintain, the goal is to maintain stable housing and live productively in the community. And so in the Healthy Homes project, at the time, so this was back in like 2010, at the time, there weren't a lot of housing vouchers or opportunities for housing. And so SAMHSA actually didn't make housing a requirement. In the other two studies, housing was in fact a requirement. And so back to permanent supportive housing, it really targets people who are chronically homeless, disabled and homeless for long periods of time, or repeatedly homeless, or highly vulnerable because of chronic disabilities. And an important point on this slide is that permanent supportive housing is an evidence-based practice. It has a very long history of research and support. And the most recent systematic review conducted in 2020 is a really nice document to read for those who are interested in permanent supportive housing and the impact on various domains. So an important point with all of the sort of the grants that we've had around permanent supportive housing is when we planned for the delivery of permanent supportive housing, we intentionally included certified peer support workers. And this is an important point because certified peer support workers haven't been included traditionally in the delivery of permanent supportive housing. And so we felt that we could really contribute to the literature when we started to look at outcomes of a peer supportive housing model that was delivered by a team that included peer support workers. Okay. So as I mentioned earlier, all SAMHSA grants or grantees are required to use the national outcomes measures, which includes various domains. And the domains include access capacity, functioning, stability in housing, education and employment, crime and criminal justice, retention, perception of care, social connectedness, the use of an evidence-based practice. In all this research was permanent supportive housing, and there were a couple of other evidence-based practices that we included as well. And then we also sometimes look at cost efficiency, but not always. And so, as I mentioned earlier, data are typically collected at baseline and then every 6 months until discharge from services. And then depending on the study and the interest of the community members and stakeholders and the community academic partnership, as I mentioned earlier, we kind of include other measures, kind of based on interest. So you've seen this slide before, but what's different is the research that has resulted secondary to the primary sort of outcome of looking at the impact of permanent supportive housing on all of those outcomes that I presented on the earlier, slide. But what we did, kind of based on different research questions that community members had along the way, we used data from each of these grants, Healthy Homes, HHRHI, and Opening Doors, to ask or answer research questions that were kind of secondary, but just almost as important in terms of interest. And so we used the Healthy Homes data to look at the impact of housing on outcomes. Because remember, I told you earlier that in the Healthy Homes grant, housing was not a requirement. And we really wanted to show that, in fact, it should be a requirement, right, when you're providing permanent supportive housing. So we took all of the data that we collected and we looked at specifically kind of the impact of housing, almost like a mechanism of change on outcomes. So we used, in a second study, we used the HHRHI data to look at the impact of permanent supportive housing on psychological integration. And then more recently, we combined Opening Doors data and HHRHI data to look at the impact of COVID-19 on individuals seeking housing and support services. So I will go into each of those studies now just in a little more detail. So the first study, as I mentioned, is using the Healthy Homes data. And this study was published in Psychological Services back in 2017. So as I mentioned, the purpose of this study was really to examine the mechanism of change within the permanent supportive housing model. And that mechanism of change was the impact of housing, which we knew was such an important component in terms of improving outcomes for individuals who were seeking housing support services. So we examined the impact of housing on 3 outcomes: overall health, psychological distress, and whether they experienced the extent to which people were reporting bothersome symptoms. And we hypothesized that better outcomes would be observed among clients who were housed compared to individuals who were not housed. So of the 237 individuals that we enrolled, 61%, so about 145, received housing. The other percent, 39%, did not. And we examined the effect of housing on outcomes 6 and 12 months post-baseline. And using a generalized linear mixed model, we found that housing was significantly associated with good to excellent overall health at the 6-month reassessment, not surprising. And then it was also associated with lower psychological distress at 6 months and the lack of bothersome symptoms at 6 months, although the last 2 weren't significant. They were kind of approaching significance, but at 6 months, we didn't find them to be significant. And so we concluded that first of all, this was the first study to examine the impact of housing within the context of the permanent supportive housing model delivered by certified peer support workers on health and mental health over time. And we did find that, in fact, housing was important and had a significant sort of impact on mental health. But it wasn't the main player in this model, right? You need housing and you also need services, which is what the permanent supportive housing model is. It's kind of a combination of the provision of housing with wraparound services. So both components or both mechanisms of this model are important. Okay. So the next example that I'm going to talk about is, as I mentioned before, we use the HHRHI data. And this study was published in the Journal of Social Sciences just last year. And this study really looked at the association between psychological integration and permanent supportive housing. And so, as I mentioned earlier, permanent supportive housing has been linked to a number of valuable outcomes, including reduced hospitalization and homelessness, reduced emergency care, increased utilization in terms of mental health services, improved mental health status, and improved quality of life. But despite all of the research that's been conducted on permanent supportive housing, there's very little research on the association between permanent supportive housing and community integration, specifically psychological integration, despite it being a core goal of the permanent supportive housing model. And the research has shown that psychological integration is a real important sort of catalyst for recovery for persons with mental illness. So we were really interested to see kind of the extent to which permanent supportive housing impacted psychological integration and to identify whether there were variables associated with sense of belonging. Excuse me, got a tickle in my throat. So also, kind of given the differences in outcomes of permanent supportive housing by ethnicity that's been reported in the literature, we were also interested to determine if an association existed between permanent supportive housing and psychological integration, whether it was equally observed among Hispanics and non-Hispanics. And a lot of the research that we do at CBH, we try to look at sort of outcomes within the lens of different ethnic groups and race groups. And here in Hawaii, here in New Mexico, we are in a really unique position to do that. the Hawaii was a slip because I was looking at some of my research earlier today that I conducted in Hawaii. All right, so so I just want to, before I go into the results, I'll just kind of go over what we mean by psychological integration. And it really is kind of conceptualized as sort of a sense of belonging. And it's one of three dimensions within the community integration conceptual model that was sort of identified by Wong and Solomon back in 2002. And so along with psychological integration, the model also includes social integration and physical integration. But we specifically focused on psychological integration. And what's really important is that the model of community integration was sort of conceptualized or sort of operationalized with the supportive housing model in mind. And so it was really appropriate for us to look at psychological integration with respect to permanent supportive housing. So in this particular study, we had 370 individuals who completed a baseline interview. And then we had follow-up data at 6 months on 286 individuals, and 143 individuals completed a discharge interview. And just a note here, this sort of attrition from 370 to 286 to 143 is unfortunately very typical of the type of research we do at the Division of Community Behavioral Health, because we work with such populations that tend to be lost to follow-up for various reasons, right? Unfortunately, there's high mortality among our population, there's high criminal justice involvement among the populations that we work with, and a lot of transition among the populations that we work with as well. So what we found was that, in fact, permanent supportive housing was associated with psychological integration. So on the instrument that we use to measure psychological integration, the range of scores was from 4 to 20. And at baseline, individuals had a score on the psychological integration score of 10.78. This was an average score. 6 months post-baseline, the psychological perception of psychological integration increased to 13.24. And then at discharge, it stayed the same as sort of the 6-month rating at 13.06. So there was a significant difference from 6 months assessment compared to baseline, and then again at discharge assessment compared to baseline. There were also significant predictors of psychological integration, including sort of ratings of overall health, excuse me, the extent to which they had interactions with family and or friends, their ratings of PTSD symptoms, and income, education, and diagnosis were all sort of significant predictors of ratings of psychological integration. And what was really interesting was that psychological integration scores were similar for Hispanics and non-Hispanics. And we believe that we found that they were equal in terms of their ratings was because we took a lot of care in ensuring that the delivery of permanent supportive housing and all of the kind of the services within that model were sort of provided in a very culturally and sort of trauma-informed way. And so the work that we did up front in training all of our providers with respect to delivering those services, I think influenced the results with respect to having equal ratings of psychological integration among Hispanics and non-Hispanics. So the thing to sort of emphasize is that this study was conducted prior to COVID-19, and it's likely that psychological integration among individuals enrolled in permanent supportive housing programs has been substantially impacted from the required social isolation, sort of our stay-at-home orders that have happened over the past 2 years. And so we've thought a lot about sort of the the community academic partnership that I'm involved in, we thought a lot about sort of the impact of COVID-19 on individuals who are homeless and who are enrolled in permanent supportive housing programs, and that there's, likely a great need for the opportunities for socialization, right? Such as walking groups and movie nights to encourage positive social opportunities to occur, and that those events are probably necessary more so now than ever before. So this is a nice segue. It leads me into the third study that we conducted, where we used the data from the HHRHI grant and the data that we're currently collecting from the Opening Doors grant to look at the impact of COVID on adults experiencing homelessness. And we looked specifically at PTSD symptom severity and overall quality of life and general health. And so we just submitted this manuscript to the International Journal on Homelessness, and there was a special edition regarding COVID-19. So we were super excited. We felt that this research aligned really nicely with this special issue. So we're waiting to hear back from reviewers. So just a quick overview of the study background for this particular offshoot. So although enacted to protect the public by reducing the spread of COVID-19, evidence is accumulating that stay-at-home orders have had far-reaching negative consequences on mental health, quality of life, and general health, for the general population. And all of you in the department who provide services, whether as psychiatrists or psychologists, have, you live this every day, right? This isn't anything new to you. Because you have seen this firsthand. But this is especially true for vulnerable populations, such as those who are homeless. These individuals that, they didn't have a home and they relied on shelters or public spaces for safety, hygiene, and basic needs. And, kind of at the height of COVID, some of those shelters were, some shelters across the country were closed. Some were definitely reduced in terms of the number of people that they could serve. A lot of individuals who were homeless, couldn't congregate in like bus shelters. And so it was really, really a challenging time, and continues to be a challenging time for them. But also something to keep in mind is that individuals who are homeless are more likely than the general population to have been struggling with the mental illness, poor quality of life, and or general health issues, even well before the pandemic, right? And so the stay-at-home orders resulting from COVID-19 likely just exacerbated those even further. And so the impetus for this particular study, actually, as with all the other sort of studies that I talked about, came from conversation with the housing service providers at the LifeLink and here at St. Martin's HopeWorks, who were really concerned with sort of the change in symptom acuity among adults who were seeking housing support services during COVID compared to those seeking services pre-COVID. The service providers kept saying, we're really seeing a difference in terms of the type of individuals who are accessing our services now compared to before. And so given our longstanding history of conducting mental health services research and evaluation, with this population kind of dating back to 2010, using that same protocol, really using the NOMS and the PCLC to measure PTSD symptom severity, using, partnering with the same agencies in New Mexico, we were really kind of in a unique position to explore whether their clinical impressions were accurate. And so the primary objective of this study was to explore whether there were differences in ratings of PTSD symptom severity and overall quality of life, general health among adults who were seeking housing assistance pre-COVID compared to during COVID, while controlling for covariates that may impact these variables. And so just a quick overview of methodology. So as with all of the other studies, it sort of focused on adults or those over 18. diagnosed with a mental health or substance use disorder. Again, as I mentioned earlier, the data from the studies from which we kind of drew our data from were identical with respect to methodology. They were conducted in Santa Fe and Bernalillo counties, and participants were recruited from the same community-based agencies within those counties. And so the data for the pre-COVID study came from the HHRHI data. So that was data collected from 2016 to September 2018. And the during COVID-19 sort of study, or the data, came from the Opening Doors program. As I mentioned earlier, that study is funded through to 2005. So we took sort of the data that we had collected thus far between August 2020 and December 2021. And so just in terms of demographics, we looked at a lot of different variables, but I wanted just to highlight a couple here on this slide. So we are in fact seeing, similar to what the providers are saying, some significant differences in the individuals that are seeking housing support services. So during COVID, there tends to be more Hispanic individuals compared to kind of pre-COVID. There was a significant difference there. During COVID, we're seeing a lot younger individuals seeking housing support services compared to pre-COVID. And in terms of diagnosis, in terms of during COVID-19 cohort, we have a lot more individuals who have a co-occurring mental illness or substance use disorder compared to the pre-COVID-19 cohort. And then in terms of our two outcome variables that we focused on, as I mentioned earlier, we used the PCLC to measure PTSD symptom severity. And so with the PCLC, higher scores reflect higher symptom severity. And we have seen a significant increase in PTSD symptom severity among those individuals seeking housing support services during COVID, kind of over the past couple of years. The average score was 54.16 compared to the pre-COVID cohort. And then we also saw a difference, or we're seeing a difference in terms of ratings of overall quality of life and general health. With this particular instrument, lower scores reflect poorer ratings of quality of life. And so we have seen a decrease in their ratings of quality of life among those individuals seeking housing support services during COVID compared to pre-COVID, although that difference isn't significant, so it's reaching significant difference. All right, and then I am not going to spend too much time on these next two slides, but the next two slides, this slide and the one after, show the results of the GLM ANOVA models that we used to look at sort of the pre-COVID-19 cohort and the during COVID-19 cohort with respect to quality of life, ratings on their quality of life and general health while controlling for a number of variables. And the time point was significant still while controlling for a number of variables. So there was still a significant difference in the way individuals are rating their quality of life during COVID compared to pre-COVID. And then here are the results for the PTSD symptom severity. The time point variable is not significant at 0.05, but again, reaching significance. So just in terms of conclusions and sort of the implications of this particular study, those who sought housing support services during COVID-19 were significantly more likely than those seeking assistance for housing pre-COVID-19 to be Hispanic and younger. They were more likely to be diagnosed with co-occurring mental illness, substance use disorder. Controlling for multiple covariates, perceptions of overall quality of life and general health scores were poorer, and PTSD symptom severity was higher among those seeking services during COVID compared to those seeking services pre-COVID. And then the findings suggest that the need for behavioral health among those seeking housing support services is greater now than ever before. Okay, So as I wrap up my presentation, it's really important that I mention that community academic partnerships don't happen overnight. And it takes a lot of extra time to nurture and to cultivate those relationships between academic researchers and community stakeholders. And those relationships really need to be based on trust and respect, and that takes time. And so as I mentioned, I've been working with the providers here in New Mexico since I moved here back in 2010. But done, if done correctly, community academic partnerships can be really meaningful and productive, and can lead to a lot of offshoots in terms of research like the ones I described here. And I think the most important thing also to remember is that community academic partnerships can really accelerate the successful dissemination and implementation of evidence-based treatment, and can be particularly beneficial for communities that have historically not been involved in research as partners, right? They've been involved in research in terms of us, again, helicoptering in, but to have them at the table as equal partners is super important. So the next two slides are just some citations that of references that of information that I refer to in this PowerPoint, and that might be of interest to some of you. And then I will end with this last picture that was actually taken from my balcony on a nice fall night here in New Mexico. So I will stop sharing and open it up for questions. And I think we have about 9 or so minutes for questions, with the goal of ending around 5 minutes to 2.
Very much value your presentation, Dr. Chrysanthe. So it's open for questions or comments. So if you virtually or physically raise your hand or just speak up. And I see that Abby has unmuted himself.
Thanks, Mauricia. Annette, just a wonderful presentation. And one of the things, you're a very modest person, that you've impacted service delivery in this state considerably. And one of the most important things I think that you've done is provided support for the unique skills and capacities of peer support workers. And I think your work has supported the state not only certifying peer support workers, but providing a way to use Medicaid funds to pay for their services. So that needs to be applauded significantly.
Thanks, Avi.
Other questions or comments? Can I look at the second page?
Dr. Towen, while people are maybe thinking about their question or comments, one thing I do want to mention for the residents who are on, who have joined, the grand rounds today, is to just emphasize that we do have now a very nice sort of database from dating back to 2010. That includes a lot of data on a large number of individuals. So if anybody's interested in doing some sort of more focused work in the area of homelessness, we do have nice secondary data that will allow for that.
Thank you, Dr. Chrysanthe, for focusing on our future, our trainees, and always making an effort of getting them involved in our research efforts. Any thoughts from our residents? And I do see a number of you there, but I think, Abby, you want to make another point. Please go ahead, Abby.
Well, I thought it would be helpful in it if you talked a little bit about for assessment for such a high-risk population without permanent housing, how you go about follow-up and assessment, the special kinds of skills that your assessors needed to learn.
Oh, wow, Abby, that's a good question. So, I mean, there's so many, right? Because individuals with who are seeking housing support services are experiencing challenges in multiple domains and areas in their lives. But I know specifically within the grants that we have had, like Healthy Homes, HHRHI, and Opening Doors, we also provide trauma-specific services, typically through the model Seeking Safety. And so it's really important to recognize that the individuals who are presenting for services have very long histories of and repeated exposures to trauma. And so it's important for our providers to be trained in trauma-specific services. And thanks to Avi, he's helped us tremendously with that. We also provide services around working sort of their supportive employment, so helping them build their resume and help them look for employment opportunities, supportive education. A lot of them, again, don't come in with their high school diploma, and so we help them with that. Food and other sort of services. Many of them come in with many different physical health problems, having not seen a doctor for many years. So that's something that our providers sort of help them connect them into, like with a nurse and primary care physician, primary services, healthcare services. Gosh, so many. So is that what you were getting at, Avi?
Yes, thank you.
One of our learners, Dr. Holguin, makes an important comment, which since we're one of the poorest states, focusing on homelessness makes a lot of sense. And one of the visions that we have in the department is, when it comes to research, we need to focus on New Mexico needs. So good point, Dr. Holguin, and again, Dr. Chrysanthe, your research like the one you do will benefit our state and those in our state who suffer from mental illness and, of course, homelessness. Other questions, other comments? Well, it's always good to leave time for folks to provide their feedback, and those of you who want to register for the presentation, that way you can be on time for your next meeting. So with your permission, Dr. Chrysanthe, we can stop this presentation again. And again, thank you much for not only for the presentation, but also for the very productive research that you conduct within our department.
Thank you, Dr. Cohen.